Thank you. Thank you so much, Dr. Patel, for the invitation and for the great introduction. I'm excited to be here amongst some of the mentors that I've had over the years, Dr. Wong, and meeting new friends. It's really an honor to be here, and especially to be invited by such great colleagues. So Dr. Patel asked me to talk a bit about sublingual immunotherapy. This is something that I have actually been doing since I was a fellow in rhinology back in 2006, and developed the allergy practice at Emory with a lot of sublingual immunotherapy practiced within our division. We also do subcutaneous immunotherapy as well. And this is something that I've been passionate about teaching about and lecturing about, and I'm excited to share it with you. These are my financial disclosures. None of them are distinctly related to sublingual immunotherapy or actually any immunotherapy companies. One of the things about when we talk about sublingual immunotherapy is that the aqueous allergens that are available in the US that are used for subcutaneous immunotherapy and often used for sublingual are not FDA approved for sublingual indications. So it's an off-label use. And so I just want to highlight that as well. So we're going to look today at the efficacy and safety of sublingual immunotherapy and some of the practical applications, and then perhaps where some of the needs are in the future for better understanding. So with that, we'll just jump right in. Initially, I'm going to talk about allergy prevalence and indications for immunotherapy. So overall, about 20 to 25% of people manifest clinical allergy in some form. In our otolaryngology world, we often see this as allergic rhinitis, sometimes with coincident asthma, but there's lots of various manifestations of allergy. And it's one of the most common chronic diseases, especially among children. So the third most common chronic disease for children under 18. It costs a lot of money to treat allergy. And this can come in the form of physician's visits, indirect costs. Certainly, we have a lot of over-the-counter medical options for pharmacotherapy these days, but it's one of the most costly diseases to treat overall in general. It's also important to recognize that allergy is under-recognized and undertreated, and this has both physician factors and patient factors at the heart of it. So as physicians, we often fail to recognize the symptoms of allergy. We don't screen for it very well. We overestimate patient control with medications. And we don't really ask if patients need to advance their therapy. On the patient side, patients are often non-adherent to our recommended treatment plans, whether that's avoidance or medical therapy for various reasons. A lot of these relate to social determinants of health and access to care and the ability to institute different regimens. And then also there can be lack of efficacy and safety or side effects of our treatment regimens. So just something to keep in mind as you're seeing these patients in clinic. When we treat allergy, there's really kind of three prongs to the treatment. So avoidance, this is something we talk about a lot. The evidence for avoidance is actually not that great. And when I say avoidance, that includes things like environmental controls, dust mite covers, taking out carpet and replacing with hardwoods and things like that. In most studies of avoidance measures, they actually tend to look at the reduction in allergen load rather than symptom control. And so really we need to understand more about how changes in instituting environmental controls actually affects our patients' symptoms. Certainly, there are pharmacotherapy options, intranasal corticosteroids, antihistamines, decongestants. As I mentioned before, a lot of these are available over the counter now, and then immunotherapy options. Just 2 weeks ago, the American Academy of Otolaryngology published its clinical practice guideline update on allergy immunotherapy. And their updated statement, slightly paraphrased, is clinicians should offer immunotherapy for patients with allergic rhinitis with or without allergic asthma if their patient's symptoms are inadequately controlled with medical therapy, allergen avoidance, or both. So our sort of parent society in otolaryngology is advocating for this treatment. What are the indications for immunotherapy? So focusing really kind of on the top area of this slide, allergic rhinitis, the indications for allergic asthma actually follow pretty closely. So poor response to allergen avoidance, environmental controls, or pharmacotherapy, adverse effects of medication, the desire to avoid really long-term treatment with medications, coexisting allergic rhinitis and asthma, and the possible prevention of asthma in children. There's actually some data to show that if we treat allergic rhinitis early in children, especially with immunotherapy, that we can prevent the progression to asthma. And asthma has, as we know, has very significant morbidity. So let's look a little bit at the history of sublingual immunotherapy. So a lot of people here in the US actually think that sublingual immunotherapy is a relatively new thing that we're doing. It's actually not that new. Back in 1900, a gentleman named Curtis actually reported ingesting whole weed extract to treat hay fever. And he did this successfully, and then various other people tried it and developed anaphylaxis. So in general, if you eat something that you're allergic to, you'll tend to have reactions to it. So that did not go over so well. It was then sort of learned that this kind of quantified and measured administration of allergen and kind of building up the immunologic protection is really what is kind of key to immunotherapy. So Noon introduced kind of this quantified in the subcutaneous form in 1911 and gave escalating doses and really measured that measured the effect by conjunctival reactivity. In the 1940s, sublingual immunotherapy was actually practiced fairly widely in the US. It was taught at courses. The American Academy of Otolaryngologic Allergy, which, as you all know, still exists today, taught SLIT at its meetings in the 1960s to 80s. And then after that, it sort of fell out of favor as subcutaneous immunotherapy was more practiced. In 1986, there was a report by the British Committee on the Safety of Medicines where they noted that there were 26 deaths from anaphylaxis related to subcutaneous immunotherapy. And so in England, they really kind of widely questioned the safety of subcutaneous immunotherapy and basically said that from then on, if you were giving subcutaneous immunotherapy injections, you had to have a 2-hour monitoring period after each injection, and you had to have full CPR and sort of resuscitation capabilities. And so if you imagine a therapy where people are kind of coming every week or even more often to get injections, having to wait in the doctor's office for 2 hours after each injection, people really just did not like that, and were not really signing up for that therapy. And so there was more interest in alternative routes. So intranasal, oral, bronchial, sublingual. Intranasal, oral, and bronchial, to say the least, have not really gone anywhere. We addressed those in our recent consensus document, if you'd like to kind of read about the evidence and trials around those, but sublingual has stayed. So around sort of the late 1990s, early 2000s, lots of different allergy organizations endorsed sublingual immunotherapy as a viable alternative for immunotherapy. So in addition to subcutaneous, and then you can see that there's been actually a lot of interest in sublingual immunotherapy worldwide. So in about 25 years, The publications in PubMed went from 21 to over 2,500 publications on sublingual immunotherapy. And there are now 107 as of 3 days ago or something when I updated these numbers. There are 107 clinical trials registered on clinicaltrials.gov. And in 2014, SLIT tablets were approved by the FDA for use in the US. And we'll talk more about the tablets here in a moment. So one of the things that is particularly, that really needs to be highlighted about sublingual immunotherapy is its safety profile. And this is one of the things that kind of makes people gravitate towards SLIT. So in order to really understand why SLIT is safe, we kind of need to understand subcutaneous immunotherapy and what sort of the risk of anaphylaxis and potentially death is with that, so that we can sort of compare them. So in various large-scale studies and Cochrane reviews, a couple of them are listed here. If subcutaneous immunotherapy is given for allergic rhinitis, there's about a 0.1% incidence of the use of epinephrine for to treat a systemic reaction or anaphylaxis. And that tends to be a bit higher if the patient has asthma. We know that patients who are asthmatic tend to be a bit more reactive in this setting. There was a very large study over about a 5-year period by the American Academy of Allergy, Asthma, and Immunology, combined with the American College of Allergy and Asthma Immunology, is known as the Joint Task Force. And they looked at nearly 29 million injection visits in practice and found a systemic reaction rate of 0.1%. So this kind of goes with the Cochrane review. And a grade 4 reaction, so the most significant or most severe reaction was about 0.1 per 10,000 injections. And there were 4 fatalities reported in this study. So just think for a moment about the fact that if you're getting an injection, if you're getting a therapy for allergic rhinitis, which basically is itchy, runny nose, allergic conjunctivitis, to think about the fact that you could potentially die from that therapy, right? So I don't want to minimize the quality of life impact of allergic rhinitis, but to actually potentially have a reaction that could cause you to be hospitalized or even die from it is significant. So what about the systemic reactions with sublingual immunotherapy? There was also a Joint Task Force report published now nearly 20 years ago that basically looked at sublingual immunotherapy, systemic reaction rate, low, but importantly, no fatalities. And to this day, I am not personally aware of anyone who has had a fatality with sublingual immunotherapy. And every time I talk about this, I ask people to please let me know if that changes, because I don't want to give wrong information. But at this point, there are reports of anaphylaxis, but no fatalities to my knowledge. And then there are a handful of other studies, pediatric, no severe systemic reactions or fatal reactions. And a meta-analysis comparison in 2012, no fatalities similarly. What about anaphylaxis? As I mentioned, it does occur with SLIT, and these are just a couple of the early reports and some of the things that might potentially lead people to develop anaphylaxis. So being treated with multiple allergens, undergoing rush therapy, which is kind of a very accelerated escalation phase, and being treated for latex allergy, which is not really an environmental allergy. One report of a teenage girl who took 3 weeks off and then decided to kind of make that up with a really significant increased dose, so developed anaphylaxis. So at the bottom, you can see some of the suggestions for potentially increased risk for systemic reactions. These are very similar to the things that we see as potentially increased reactions with subcutaneous immunotherapy. And then at the top, you can see that the risk of anaphylaxis with SLIT was calculated about 10, 12 years ago, and it's one case of anaphylaxis per 100 million doses of SLIT. So I think that the difference in numbers between SCIT and SLIT for anaphylaxis is on orders of magnitude. So it is considered a safer therapy. Doesn't mean you don't need to be cautious. The safety profile is higher, but with any method of immunotherapy, we're giving small but escalating doses of things that we know the patients are allergic to. We have tested them. They have symptoms. They react to it. So we are, we know that there's the chance of significant reaction, and we want to keep that in mind. All right, so for the next portion, I'm going to talk a bit about efficacy. So we have generally a safe therapy, and now we want to know if that therapy works, and that's important, right? We want to be able to tell our patients, are they going to improve? So the first randomized controlled trial of sublingual immunotherapy was in 1986 by Scatting and Brostoff, who were in the UK. Interestingly, the exact same year that British Committee on the Safety of Medicines report came out that questioned the safety of subcutaneous immunotherapy. The first large-scale efficacy trials of SLIT were in the GRASS tablets and were published in 2011. And then, as I mentioned before, SLIT tablets were approved in 2014. And I mentioned this at the beginning, but I'll mention it again. The currently available aqueous antigens, so what we get from manufacturers that we mix for shots, for allergy shots, subcutaneous immunotherapy, are not FDA approved for SLIT. We use them off-label. So how do we define efficacy in allergy trials? And I think this is important to understand. Two main measures that are assessed. Number one is symptom control. So typically by validated symptom measures such as the total nasal symptom score, and then medication use. So daily medication, measurements of daily medication use, rescue medication use, things like that. Quality of life assessments we will often see. So the main one that's used is called the mini rhinoconjunctivitis quality of life questionnaire. And then objective measures often kind of go along with this, but objective measures are not usually the main measures on which study outcomes are based. So we can see things like immunologic changes, provocation test, skin test reactivity, and then for asthmatics, lung function. Studies, like with anything in the literature, studies have wide variation in defining their measures of efficacy. Important to realize that, like anything, when we use a measure, there's a clinically relevant change. So basically, essentially like the MCID, 20% is the number to keep in mind for symptom improvement in allergy studies. And then you can see there's variation in some of the treatment parameters with respect to duration, schedule, dosing, and various antigens. Efficacy for immunotherapy in general has been shown for lots of different allergic diseases in both adults and children. And then specifically for SLIT, I'm going to go through some of the efficacy data so that you'll kind of be aware of what the therapy can help with. And the tables that you'll see on the following slides came from our recent international consensus statement on allergy and rhinology for allergic rhinitis, which was updated and published in 2023. And I was honored to lead this effort. So these various tables, I'm just going to kind of orient you to the table because I'll move quickly through the next few slides. So on the far left column is what we're looking at. So efficacy for symptom reduction, and this is all related to allergic rhinitis because that's what the document was about. So efficacy for the reduction of allergic rhinitis in adults, children, safety, and then we'll go through some of the other things on subsequent slides. The aggregate grade of evidence is the next column. So A is the best, B is slightly less. A is basically meta-analyses. There's a lot of studies in allergic rhinitis. There are a lot of meta-analyses. The data for allergic rhinitis is much stronger than anything we have in rhinology. And I know that because I am a rhinologist also, and I've looked at the data in both areas. The direction of impact basically says that that statement is positive. If it says no, then that statement is negative. The magnitude of impact, you can see it may be low or high. And then the recommendation level is basically strong recommendation, recommendation option, things like that. And then the second row for each of these is just kind of the data to support it. So essentially all of the references that you'll see are meta-analyses. So for efficacy in general, evidence is slightly better for adults, but still very strong for children. For safety, it basically mirrors that. So safe in both. Oftentimes asked, which one is better? And we'll talk a little bit more in depth about this. Is subcutaneous or sublingual immunotherapy better? The evidence currently says that subcutaneous immunotherapy is probably a bit more effective than sublingual immunotherapy. On balance, when we're talking to patients about therapy, efficacy is part of it. Other things that go into the discussion, safety, cost, convenience, things like that. SLIT is safer than SCIT. Yes, good evidence to show that. Total cost of SLIT is less. For a treatment course, the treatment course is typically 3 to 5 years for any immunotherapy option. Total cost, generally less than SCIT. SLIT comes in basically one FDA-approved form, tablets, and then aqueous off-label. Tablet SLIT is more effective than pharmacotherapy. Good evidence to show that. It's safe to continue SLIT during pregnancy. It is safe to continue SLIT during pregnancy. We do not initiate it during pregnancy. But if the patient is already on a treatment regimen, we can continue that. And that is also true for subcutaneous immunotherapy. It's safe to start SLIT during the season in which the patient experiences allergy. There used to be this thought that you can't start them in the season because they'll get so reactive. It's actually safe to start them in the season. SLIT is cost effective in the first year. Actually, it is not really cost effective in the first year. They need more treatment than just a year in order to make it cost effective. But then it does become cost effective after several years. Long-term effects beyond 3 years, meaning when we're working to change the immunology, the systemic immune reaction, does that last? Yes, it does. So the patient can stop therapy after the 3 to 5 years of treatment, and those immunologic effects and those symptom changes will persist. That's been studied up to about 7 to 8 years. Preventative effects, I mentioned this early in the beginning. SLIT has a preventative effect. It can reduce the development of asthma in children. And then the various allergens, you can see the evidence here. I'm not going to go through these in depth, but really good evidence for grass pollen, tree pollen, and ragweed. Also for house dust mite, a little bit less for some of the other allergens as far as the studies that have been done. So the summary recommendation overall for SLIT, based on at least 17 meta-analyses, high level of evidence, strong recommendation for SLIT, and then the specifics of the various allergens are here. So that's overall, that's tablets, aqueous. For tablets specifically, there are 11 studies, and that carries a strong recommendation. And then for aqueous, the evidence is a little bit less strong, so grade B, and carries a recommendation. So in general, lots of clinical trials, large-scale studies, meta-analyses, comparisons, et cetera, and essentially saying that SLIT is efficacious for the treatment of allergic rhinitis. I mentioned briefly that I'm often asked which is better, SLIT or SCIT. If you were to study this in a real kind of rigorous way in a clinical trial, with all of the blinding that should happen, it's called a randomized, double-blind, placebo-controlled, double dummy design. Basically meaning every patient in that study receives sublingual drops or tablets, whatever you're studying, and an injection. There are placebos inserted where necessary. So there's essentially a group that receives everything placebo. There's a group that receives placebo shots and active drops. There's a group that receives placebo drops and active shots, right? Little bit hard to sign people up where at least 2/3 of the groups receive placebo injections for 3 to 5 years. So it has been done in small studies. This is an example of one. And basically what they found was that both immunotherapy methods were better than placebo, but it wasn't really powered to detect a difference between the two immunotherapy methods. There have been indirect comparisons. So basically meta-analysis based indirect comparisons. These are just some examples. Essentially what many of these say is that the efficacy of subcutaneous immunotherapy is probably a little better than SLIT, but they all sort of qualify that with no direct studies, no large-scale direct studies have been done. Couple quick words about dosing. When we give immunotherapy, the dose is important. I mentioned very early that if you just start eating ragweed and you're allergic to it, you'll probably get anaphylaxis. So that's kind of not a good idea. But if you start with small doses and work up to what's kind of called the target dose that changes your body's immunologic reactivity, then you can get good response and long-term response. So the optimal, starting with kind of the subcutaneous immunotherapy idea, the optimal maintenance dose is the dose of allergen vaccine or immunotherapy that induces a clinically relevant effect in the majority of patients without causing unacceptable side effects, right? And this is kind of like drug studies, right? You want something that works and you don't want a lot of side effects. And that's been worked out for subcutaneous immunotherapy at 5 to 20 micrograms of major allergen, or the protein that causes the reaction, per month. And really, relatively limited number of studies were actually dose response based. We know that for SLIT, that dose is higher, but in trials, the effective dose of allergen for SLIT is somewhere between 300 and 500 times the SCIT dose. So it's a pretty wide range, and there's lots of different options for how frequently that's given and treatment duration. Ideally, we would have large-scale dose response studies with a consistent allergen content that are given to a lot of patients. We figure out the dose, but those are really expensive and are not done very frequently. So a lot of times we're just extrapolating from the various studies that have been performed. Also, adding to the confusion, studies vary in different allergen content. So this is not like, allergen content is not like, giving someone 10 milligrams of metoprolol, right? We know like that is manufactured. We know what that dose is. When allergen comes from a manufacturer, it's because they've harvested it out of a field. They've basically put it through a giant, essentially coffee filter, and they, have purified the protein. But there's different elements of reactivity, and patients react differently to those proteins. And so you get a little bit of some different measurements of actual kind of sensitivity and reactivity. And in different countries, they work by different reference standards. So for example, in the EU, they have proprietary units. Each manufacturer has their own reference standard, and then they test them in vivo on allergic patients. In the US, this is regulated by the FDA, and they do in vitro potency tests, which are, you can imagine that's a little bit different. And there's all these different units, and the units vary by the actual allergens. So it's pretty complicated from the standpoint of like putting it all together and understanding what's going on from one manufacturer to another and from one unit to another. But we know that the dose of sublingual should be more than the dose of subcutaneous. And in general, this is kind of the number that I think about, that median. It's about 50 times the dose. So the dose that we're placing under the tongue is about 50 times the dose that's injected of the same allergen. So also for children, the pediatric immunotherapy doses are generally equivalent to the adult dose. So we don't have to do special calculations for pediatric dosing. But sometimes in very young children, they may not be able to tolerate the maximum adult dose. I'm going to skip just by this. Luckily, there have been some publications. This was done by the AAOA a few years back that looked at kind of all the evidence for dosing and put it in these nice charts and said, this is what you should give your patients. So we follow this in general, especially when we're trying to push doses up. So I have mentioned a couple times about escalation. What do I mean by that? We start low with the doses and we work that up over a period of time. That period of time is relatively short for sublingual immunotherapy, but with a few exceptions, we don't want to just give them all like the recommended dose all at once. So we're kind of balancing the risk of adverse reaction to the effective dose. Now, SLIT does have the higher safety profile, as I mentioned, relatively rare anaphylaxis, no deaths that I'm aware of. And we think that that's because of the tolerance of the oral mucosa. Just think about the amount of things that our mouth is exposed to all the time, new foods, the environment, et cetera. So the oral mucosa is pretty tolerant. And so we have this higher safety profile, and so we can push those doses up pretty quickly. So basically, and I'm going to just go straight to this. We have a method of diluting the allergen out. We use 1 to 5 dilutions, and then we make one vial that is our actual patient treatment vial. So that's our maintenance vial. And then we do a 1 to 5 dilution, and that is their escalation vial. So if we're treating with aqueous off-label sublingual immunotherapy, our patients go home with 2 vials to start. They have the one that they're going to use, and then they have their little escalation vial. And this is what their very brief and easy escalation looks like. So from their escalation vial, and remember, this is a 1 to 5 dilution of that ultimate treatment vial. They take 1 drop on day 1, 2 drops on day 2, 3 drops on day 3, all the way up to 5 drops. The next day, they go to the next vial, which is 5-fold more concentrated, and they take 1 drop on day 1, and then they get up to 5 drops, and that's their treatment. So 5 drops every day from the vial, and they stay on that for, we do 4 years. So it's 3 to 5 years. We do 4 years. There's one paper that says that 4 years is better than 3, 5 years isn't better than 4, so that's where we went. Sometimes the patients will develop some symptoms as they're working their way up, and if they develop some symptoms, such as I had one patient who developed itchy ears. Every time she got to 3 drops of the second vial, her ears started itching. And we just dropped her back to 2 drops, and that's where she was. That was her dose. She just couldn't quite get up to the recommended vial, but there is something called the maximum tolerated dose, and so that's fine. Other times patients will develop itching in the mouth, sometimes a little bit of GI symptoms. Those are pretty common. So we just kind of ask them to let us know if they're having any symptoms. When they take the drops, they put the drops under their tongue for 2 minutes, and then they swallow. And if they're a child, we ask them to do it when a responsible adult is present. We initially have them, when they're first starting therapy, we have them keep a log just to kind of make sure that they're doing it regularly. We do prescribe epinephrine injectors. That's not everyone does that, but that's our protocol. I just feel better if they have one. We educate them. It is important not to just give a prescription for something, but also make sure that patients know how to use it. So we make sure that they have education on how to do epinephrine injection. We have a little demonstrator in our office. We send them home with a link to a video, et cetera. And we also train a family member as well. And then we make sure that they have an up-to-date prescription of their epinephrine, because an expired epinephrine injector does not actually do anyone any good. So there are lots of options for escalation. I've given one example. There are lots of various other options. In the US, we believe that more is better. I think everyone kind of can see that in their daily lives. So in the US, it is very common to treat with multiple allergens. And that goes for subcutaneous immunotherapy, sublingual immunotherapy. This is not the case in many other countries, particularly in Europe. They treat with 1 allergen, sometimes 2, even with shots. But here in the US, the average prescription for subcutaneous immunotherapy contains 10 allergens. The majority of studies in immunotherapy test only a single allergen. Why? Because in order to have controlled studies and to see what the effect is, you can really just test one thing, right? When there's a clinical trial for a statin, the trial doesn't include, a statin and a beta blocker and, hydrochlorothiazide, where they're testing the one thing. So similarly, immunotherapy trials have single allergens. There are a few trials that show that treating patients who have appropriate allergen sensitivity and reactivity profiles, treating them with more allergens may be better. So this is an example of one of them. Multi-allergen immunotherapy was better than single, which was better than control. There are others that go the other way. So the top one is an example of a patient or a group that was treated with either placebo versus Timothy grass extract versus Timothy grass extract plus 9 other allergens, and there was no difference. So the data's a little bit fuzzy on this, and I don't know that we'll ever see large-scale studies of lots of allergens, but that is the common clinical practice in the US for subcutaneous immunotherapy and sublingual aqueous mixes. Now, having said all of that, the FDA-approved products here in the US for SLIT are in tablet form, and they are single allergen. So this mirrors what our European colleagues do. These tablets are FDA-approved. There's now Timothy grass, short ragweed. There's a 5-grass tablet, which is all of these various members of the Timothy grass family, and there's house dust mite. And I'm gonna, understanding CME rules and all of that, I'm just gonna tell you, I will refer to these by their brand names only because for the next several slides, you do not want to hear me say short ragweed pollen alum extract tablet for sublingual use 12-AMB-A1U. That is the generic name. So single allergen treatment for patients does work. The tablet studies show that. So this is just an example. And the 5-grass tablet is considered a single allergen because it's all in the same family. So this data comes from 5 European and 1 US placebo-controlled trial. Adults and children, you can see the numbers in the study there. And basically the combined score, which is a symptom and medication score together, had clinically significant and statistically significant improvement. And I mentioned the relatively common side effect of oral and throat itching. This is the Timothy grass, some of the data from there. So they looked at the first season in which the patients were treated and then the sustained effect over 3 years, as well as post-treatment. So the patients were finished with their immunotherapy. And you can see that in the bottom, so this is combined score, daily symptom score, and daily medication score, and all of those numbers across the board. The years of active treatment and post-treatment were significant. The ragweed tablet mirrors this very similarly, although the magnitude of effect is a little bit less than with the Timothy grass. So those were the studies that kind of came together to get the indications for the SLIT tablets in the US. So the indications you can see here on the left, they have to have pollen-induced allergic rhinitis for these. They have to have some allergy test that basically shows that they have allergen-specific IgE to that. And then you can see the age, the indication of ages there. Contraindications, the main one really is severe, unstable, or uncontrolled asthma. Patients that undergo allergy testing or immunotherapy, if they have uncontrolled asthma, they are at higher risk of anaphylaxis and death. So that is a significant contraindication. The dosing, there's a small escalation period for oral air in children. The other ones actually you just start taking the tablet. So these can be prescribed in the clinic. You can also give different types of tablets together. So if the patient truly has a ragweed allergy and a grass allergy, you can give them 2 tablets. This study did that where they basically gave one in the evening, one in the morning, and then eventually they took them at the same time. I mentioned before, you can give them co-seasonally, meaning you can treat the patient in the season whether they're allergic. There is no increase in adverse effects or epinephrine administration. And then this is the data for the dust mite tablet. In my practice, this is probably the one that is prescribed the most frequently, dust mite. It's patients, as I mentioned, patients in America tend to have a lot of sensitivities and a lot of actual clinical allergic rhinitis to different allergens. But when we find someone who's really just perennially allergic, no seasonal symptoms, it's almost always dust mite. and they do pretty well with dust mite tablets. This was approved in 2017. All right, 2 immunology slides. I mentioned that the oral mucosa is tolerant. The dendritic cells have higher expression of MHC and will grab onto that allergen. And then the immunologic changes, we eventually get lower allergen-specific IgE, and then we get increases in things that make us tolerant, like IL-10. And then the final thing that I'll mention is practical stuff. What if you want to do this? How do you add this to your practice? I would say that my immunotherapy patients are some of the best patients to take care of. They're happy. So this is something that I would recommend for ENT practices in general, not just rhinology. There's allergy in laryngology, there's allergy in otology, there's allergy in certainly in peds. But you need dedicated time and space. You need meticulous staff. This is in the years that I've been running the allergy practice, the worst days of my life are the days when an allergy nurse tells me that she's leaving the practice, because they're so good, and they're so once you have them trained, they just kind of run everything, and they really keep things going, and they're the ones that have the contact with the patient week after week. They kind of become part of the patient's family. So I just hate it when people come and they're like, I have to move to Chicago, or I'm like, no. You need if you're going to do your own skin testing and vial mixing and things like that, you need quiet and clean space. There are very specific regulations by USP, which is the US Pharmacopoeia. They update them about every year, and everyone goes into a tizzy wondering what the next update and how many different things we're new and different things we're going to have to do. But really, it's a quiet and clean space, and an organized staff, and people that closely monitor things like expiration dates and things like that. I mentioned early avoidance, pharmacotherapy, and immunotherapy. I think immunotherapy is a great avenue for patients. I think that there are lots of things to consider, things like efficacy and safety, which I talked about. There's a lot that goes into cost. Aqueous sublingual immunotherapy is not covered by insurance because it's not FDA approved. That is not going to change in the future. And we can happy to discuss the reasons why outside of this forum, but it's something that there is very rarely insurance coverage for in the US. So it's an out-of-pocket charge, but patients are very happy. And once you sit down and talk to them about it, most of them are very willing to take that on. It is convenient, and patients tend to be relatively compliant. They do the sublingual immunotherapy at home, so they do not have to come into the office for shots. So I think that that's also a good benefit. So I think with that, I'll go ahead and just stop there, and happy to take any questions.
Thanks so much, Sarah. It's so great to have you here. It's a really informative talk. Just a couple questions. One is, if you were just to counsel patients on the onset of improvement, and I think sometimes the subcutaneous therapy, the barrier is like, when can you expect to have improvement? How do you compare SCIT and SLIT in that way?
Yeah, so SLIT tends to be a little earlier. So has to do a little bit with the period of escalation. So escalation for subcutaneous immunotherapy is basically weekly or twice weekly shots, and it takes several months to get up to their targeted treatment dose. Whereas, as I showed, SLIT is like days, or with the tablets, you just take the tablet. So we typically start to see improvement around 6 months with SLIT. For subcutaneous, it's closer to a year. In any patient that is concerned that they're not responding on SLIT, I encourage them to continue for at least a year to see, if they end up starting to see improvement at that point. But I don't push them really beyond that. If they're convinced that they're not seeing improvement, I don't push them beyond a year, because they're paying for it out of pocket.
Just one more question. When we were looking at developing the allergy practice here, the mixing was a non-starter with our hospital pharmacy. So if we're confining our sublingual therapies to the tablets, would you recommend monotherapy for somebody like dust mite with multiple allergens? Because sometimes we get the allergy reports and it's like, massive. Or 2 different sublingual tablets at the same time.
So a couple thoughts on that. So the allergy testing reports show sensitivity. It does not show clinical allergy. So sensitivity is the reaction to the test, the IgE reactivity to the test. Clinical allergy is having that sensitivity plus symptoms. So it's really important to kind of go back to the patient and say, when are your symptoms? What are your exposures? What is the season? Is it at home? Is it at work? What are you, and then really try to tailor things to that. In the US, 50% of people are sensitive, 20% are allergic. So my point there is definitely don't go just on the test. So there is data to show that treating with single or very few allergens can actually affect a protective sort of down regulation of the entire response. So you get an increase in Treg cells and the associated cytokines. And so even if you're treating with a single allergens or maybe 2, you can kind of dampen that overall response and potentially get a beneficial effect to, symptom-wise when you're not actually treating with certain allergens that they may be allergic.
Thanks.
Yeah.
You want to?
We can go. You can go first.
Thank you so much for this excellent and wonderful talk. I had just a couple questions. One, I've had some patients that have been placed on these Raguatec or Grasstec type tablets by just like a primary care doctor or something, and I'm not sure if it's just my ignorance about the way that they're supposed to be using these tabs, or if they're just not being prescribed correctly, but some of them will just be placed on it during the season. Yep. Is that appropriate?
So it's something called, for seasonal allergens, that's something, there's a method of treatment called pre and co-seasonal. So the interesting thing though is that pre portion is important. You actually have to take the tablet for like 12 weeks prior to the season starting, and then continue through the season. And that assumes that you can predict when the pollen is coming. And actually there are services by the manufacturers that will notify the patient. So yes, that is an accepted method of treatment. It's actually endorsed by the recent clinical practice guidelines in the Academy. Data actually does show that if you treat patients with seasonal allergies with immunotherapy year round, that they do get some incrementally more improvement than if they just are treated seasonally. But it is an accepted method.
Thanks. And then can you talk a little bit more about the cost part? Because We actually don't have this. I looked for allergists around us that will do like the aqueous sublingual, and there's really not anyone that I've found. But there are some mail sort of companies that you can send the test to, and they will mix it up and then send it to patients. And so for people who it's like, very inconvenient to come into the office once a week for that long, I'll recommend that for them. But the cost part is a hard one. Is it because of the copay that they'd have to pay for each visit that it ends up being less costly for sublingual, or does that vary across insurances, or does that vary regionally or from the manufacturer?
Yeah, so in our practice, we have more sublingual patients than we have subcutaneous patients. But I practice in Midtown Atlanta. It's an urban setting. We have a ton of traffic. The parking situation is horrendous. So the patients our patients who are on shots either work in our building, in the building next door, or they take the Emory shuttle from the main campus to come to our place. Most patients, if you factor in not just copays, but time cost and inconvenience, they will tell you that they do not want to take off. I mean, it's essentially like 2 hours or something at least, because it's the shot, the traffic, the sitting. We have a 30-minute observation period after a shot. So it's not just the dollars, it's the indirect costs as well. And there are differences in insurance companies on shot copays and that sort of thing.
Hey, Sarah, thanks again for coming. It's been great having you, and also the residents are really going to benefit from hearing, your next time, maybe an hour or two with them. I had a kind of basic science question, which is, we think of the mucosal surfaces as kind of tolerogenic environments. So that's why we don't react to the foods we eat, right? So we try to ingest foods, and we don't get reactive to chicken or so. But I don't know why the nose is a mucosal surface, but it's not something that an area that is tolerogenic. I think it's considered I think it's in between. What can for a small amount of time we have? Is there knowledge of that, or was that addressed in the ICAR statement?
Well, I mean, I think that, so we do have a significant section on sort of pathogenesis of allergic rhinitis. There's a whole bunch of immunology discussed there. But to some degree, the nose is tolerogenic, right? We're breathing this stuff in all the time. And there are, some people react to things like pollen and various other allergens. There's also, irritant rhinitis and things like that, as you know. And then similarly, within the oral mucosa, for the most part, it's tolerant, but then there are people with food allergies. So there are people that react to, certain things. Interestingly, there's some pretty good thoughts around the development of certain food allergies, and that it actually starts in the skin. So kind of skin barrier breakdown and skin exposure to things like peanut allergen is actually thought to be one of the reasons for development of peanut allergy. I don't do a lot of food allergy in my practice. As a rhinologist, I like to focus more on the nose. But yeah, I mean, I think the nose is not as tolerogenic as the oral mucosa, but to some degree it is.
No, it's interesting. I mean, also the skin, right? So skin is supposed to be reactive, and you can react to it, but then we use the skin for skit. So
exactly,
it's a fine balance. I think we just strike. The last thing I had is, or question I had is, 20% is the efficacy is the right standard, right, for symptomatic improvement, right? Which is interesting. I didn't know that metric before, because if I sneeze 50 times and then I started therapy and I only sneezed 40 times, I don't know if I'd be happy with that treatment. But But I'm sure it's more global than that. It's more like a global reduction in a global set
Right.
of
So
symptoms.
in
I'm just curious how you counsel patients about what to expect.
so that kind of comes from clinical trials. And but if you think about the MCID of the SNOT-22, which is 8.9 or 9 points out of 120, that's far less than 20%, right? But we very frequently say, oh, they've reached the MCID of the SNOT-22 because their reduction is more than 9 points. So I think that is also considered the minimal clinically important difference. Doesn't mean it's the change that every patient will experience. So I don't really talk much in the clinical setting about feeling 20% better. What I talk about more is people will ask, what's the chance I'm going to improve? And overall, about somewhere around 80% of patients on immunotherapy, or even a little bit higher, relatively similar to sinus surgery, get better on immunotherapy. So I tell them that I would say about 80% of people get better.
I think we might be out of time, but thank you so much, Sarah or Dr. Wise, for this wonderful talk.